So welcome to the South Asian Public Health Association Spotlight Series, where we shine a light on the extraordinary individuals shaping the landscape of public health with a focus on the South Asian community. We're your hosts, Mira Khan, President of the South Asian Public Health Association, also known as SAPHA, and
Loin Begum, the Communications Co-Chair for SAPHA. SAPHA is committed to advancing the health and well-being of South Asians in the U.S. and beyond, fostering collaboration, advocacy, and research to address health disparities and promote equitable outcomes. Our podcast series dives into captivating conversations with influential figures in public health. So stay tuned for inspiring stories, insightful discussions, and a closer look at the impactful work of SAPHA over the past 25 years. Learn more about us and explore the wealth of resources we offer at www.sapha.org.
So today we're continuing our journey celebrating SAPHA's 25th anniversary with our third episode. And we are honored to welcome Dr. Arnab Mukherjea, a distinguished figure in the field of public health. Dr. Mukherjea is not only an associate professor and department chair of public health at California State University, East Bay, but he's also a passionate trailblazer in public health research and advocacy, and has done a lot of work in South Asian communities. Additionally, he's played a very significant role in SAPHA. He served on its executive board of directors from 2004 to 2009, which included 2 terms as co-chair as well as chair of the communications committee. And then later, he was a special advisor to the SAPHA President in 2018 into 2019, and has also made significant contributions over the year and continues to stay engaged with all of us to this day. I feel like we meet with him all the time frequently. He's constantly giving us advice and helping us with the organization, and we're eternally grateful for that. So Dr. Mukherjea, welcome to the SAPHA Spotlight Series. We're so excited to have you here with us today.
I'm really excited to talk to both of you, and I'm very proud of the leadership of SAPHA and where you are right now.
Thank you. So as we start off today, would you be able to share a brief overview of your journey in the field of public health, especially focusing on your work with the South Asian communities?
Yeah, absolutely. When I was in graduate school for public health, and I know all of us have gone through that, oh, I'm pre-med until I'm not. And oftentimes, we knew in our hearts something we wanted to do, but either couldn't admit it to ourselves or, more frankly, admit it to our parents. And so when I fell upon public health and the idea of the obvious things that we know now, prevention at a population level, that's a very broad scope of work and of impact. So the question is, what role did I want to play? Most of us, I don't want to make generalizations, but South Asians tend to be very prideful about their identity and their cultural history, right? And many of those things that we've experienced have to do with health. And, although I was a molecular and cell biology major, I was laughing because I was listening to Umair Shah's podcast yesterday, and there's so many similarities with him and me and Ushma, and just recalling those days. The one thing I really wanted to know is, we know some of these things that we value in our culture are some of the same things that result in inequitable outcomes. And why were we not studying that, right? Why weren't we not studying, the role of being a model minority and internalizing that? Why were we not understanding that our diets, even though they're so special to us, are the same things that cause heart disease and diabetes? Why did we not understand that cancer was a bad word? So if you can't say cancer, you can't say cancer screening, right? We know all of these things, the 3 of us in this room, but yet why was that not in the literature? And when I graduated with my MPH, my, goal was sort of like, I'm going to go eliminate all South Asian health disparities, which again is, showed how naive I was. What started my sort of passion for being an advocate, a researcher, a practitioner of South Asian health really started off the fact that all 3 of us, if we were given a demographic questionnaire, we would check the Asian or Asian Pacific Islander box, and so would about 50 other people from different cultural groups. And to this day, the disaggregation issue is really something that is a systematic form of racism, because what it does is renders our communities invisible, right? It puts us into sort of this monolith, which doesn't exist. So I was very frustrated. We're taught to be sort of critical appraisals of research, and we would read research on disparities, and then we would find the Asian disparity. And I'm like, I don't even know what that means. And if I don't know what an Asian disparity is, what is the Asian intervention, right? Do we, the Asians don't pray to one God. Asians don't eat one food. Asians don't speak one language or watch one type of movie. So it seemed to me that there couldn't be a thing like targeted or tailored interventions when the category itself was nonsensical. From a intervention standpoint. And so, many of us, we do a good job of critiquing, but we often don't know what the solution is. And that's where I was really stuck, which is, yes, there's a systematic issue of disaggregation of Asian or Asian American and Pacific Islander data, but then what was the solution to that? And so I was sort of resigned to say, okay, if I'm going to do work in my community, I kind of have to piece together things that I know to be true from my lived experience, but may not be, to use the words of epidemiology, valid at a population level. And I know we're going to talk a lot about mentorship because that's something that's very near and dear to me. And I think all two of your prior speakers and I will say we have infinite number of mentors who will be offended when we don't say their names during this podcast. But one meeting I remember going out of my community-based intervention class, and it was obvious I was very frustrated because without data, we don't have a evidence base from which interventions at the policy level, at the program level should happen. And so I raised my frustration in class, and she called me in for office hours afterwards. And she said to me, I understand you're getting a little bit frustrated with the lack of granularity, and I want to help you with it. And I said, well, what are you going to do? You're not going to change the way we collect data. And she said something to me, which I swear I will, if I ever write a book, that will be one of the titles, which was, if nobody's doing it, why can't you, right? And it's a very simple statement, but in graduate school, I know for both of you, you're not taught to really be empowered to own the agenda. You're taught about all the reasons why what you want to do can't work. But to put in somebody's head, you can be the person that changes this for, a 24-year-old graduate student was very powerful. And that sort of shaped how I came upon SAPHA, to tell you the truth, was trying to find out who are the people who actually cared about the same things I did in a way where we could make meaningful community change for health. So that's a long answer and I can go on, but that's sort of the genesis of what brought me into this field we call South Asian Public Health, which is the title of your wonderful organization.
Thank you so very much. That was a really interesting, but also very inspiring start to your trajectory. So you talked about your mentor who really influenced your trajectory and brought you into South Asian research. What advice would you have for emerging public health professionals on seeking mentors?
So this is tough because mentorship means that the mentor has to have a philosophy of what mentorship means, right? So a lot of people call themselves mentors, and they're probably right to a certain extent. And I've spent a lot of time trying to figure out what are the qualities of the mentors in my life that were more than just being a technical assistant. And I think, first of all, there's no such thing as one mentor. Number one, like one person is not going to do it all. And just because you're assigned an advisor in graduate school does not mean that is the person who will be your lifelong mentor. And so I have mentors on many different dimensions of my life, professionally, personally. And I think what I've gleaned from my experiences thus far is that the good mentor is, first of all, the one that actually takes the time to listen to what you want out of the world, right? And listen, not just say, okay, you tell me what it is that you want and I'll tell you why it's wrong, or I'll tell you why it's not doable, but really takes the time to figure out what your values are. And I want to pause to talk about values because public health is dynamic. If we didn't know that prior to the pandemic, we know it now. Public health is situational. Public health is political. So if you're chasing where the winds of public health go, it's very unsatisfying because you could be working on emergency preparedness and then obesity and now respiratory illness and hunger, right? It's like you're following where the winds are. So the only thing that is constant is your value system. If you believe in health equity, it should not be situational. If you believe in community representation, it should not be situational. And yeah, do the context and the dynamics change? Absolutely, but the core value shouldn't change. And so the mentor is the one that allows you to state those things with conviction and then allows that to be your North Star on how they advise you. And the second part of that I'll say is that the good mentor is the one who may think, I'm an uncle. I proudly wear that title. I used to hate it. And now I'm like, okay, that, in our community, that's a sign of reverence, right? That you are somebody who's achieved a certain age and hopefully have experienced the world in a way that other people haven't. And the good mentor is the one that puts their agenda aside and focuses on yours. Now, that doesn't mean they don't tell you the brutal truth about the world, right? But they let you know that for you to achieve what you want to achieve, this is the road you're going to have to travel. And they may think that there's a different road for you, and that's fine, but they allow you to come to the conclusion that this road is the right road, or this road is too fraught with too many obstacles, or being a single person is very different from being a family person, and therefore your career might change because of those other priorities that you have. So in short, the good mentor is the one that say your agenda is the one I'm going to advance, and not necessarily because I think my agenda for you is better. And I think we see that in a lot of, especially academic institutions where senior faculty members, by no fault of their own, were trained in a certain way, and they think that's the way you should be trained.
It's so important, finding a good mentor is, I think, something very hard. But you have a very long history of being a mentor and also supporting a lot of underrepresented and underserved communities in public health. You've also been a very important mentor to so many of the SAPHA board members as well over the years, myself included. I feel like everyone kind of just turns to you for advice immediately because they know that, you have that reputation of being a really good mentor. So would you be able to discuss maybe a particularly rewarding mentorship experience that you've had and how it impacted your approach to mentorship?
Yeah, I think that you get to a certain age and you get a certain level of degrees and you think you're an expert on things, and we're never an expert on anything. Even a doctorate, I tell people that when they pursue it, I'm like, all you do is you know more about less, if that makes sense, right? And so, I'm at a university that's a teaching university, and I know many people who might be listening to this may think like, oh, a professor means a professor at a Research One institution. They have to publish, they have to get grants. And that is true for me, but that is not my primary charge. This institution that I'm at focuses on training students who otherwise don't have any opportunities and making them into change agents. And so I obviously so I live in the San Francisco Bay Area. As you know, not only is the model minority myth pervasive here, Silicon Valley, all of those things, but also we have many segments of the South Asian community that are very much don't live that reality. And especially my students don't. So even if they're Indian or Pakistani or Bangladeshi, even though they might be next door neighbors with the people who live that reality or think they live that reality, they sure don't. They're working full-time jobs. They're taking care of their parents, and they're trying to put their education as a priority. And so this model minority thing is really, really hard on us because it makes us have to reach up to expectations that are unpalatable to anyone. And I don't even know where those expectations came from. So a big community here in the San Francisco Bay Area, when I say big, a large community, is the Indo-Fijian community. And so Indo-Fijians are individuals or communities with origins, obviously, in the Indian subcontinent, but during partition, their ancestors were taken as indentured servants to places like Fiji, and on the East Coast is the Caribbean. So while partition was happening, a subset of people were taken to the British colonies and basically did work of indentured servitude in a place where they were not the dominant culture. And if you look at the history of, sort of the Indo-Indian presence in Fiji, at some point, Indians or people of Indian origin actually outnumbered the people of native Fijian descent. Well, if you're on island and you're like, wait a minute, who are all these people that are on my island and now they outnumber me, you're going to feel a certain way. And in fact, when a person of Indian descent won the prime ministership of Fiji, that's when there was a coup. And native Fijians felt very strongly that this is our homeland. And the coup made a lot of these folks of Indian descent basically refugee over to the West Coast and in places like Hayward, where I am. Why do I say all that? Well, those people, even though their names may be like, Samira Khan, they don't share a lot of the historical understanding of South Asian migration to the US because they're very unique. When they come to me, and I don't know if you can see my desk, but I have a Fijian boat on my desk, was given to me by one of my Indo-Fijian students, because I allowed them to really own the space. Because what do I know? I can just read books and articles. I did not go through the stories and the narratives of uncles and grandfathers who came here in that way. So today, as a couple of hours ago, one of my students was doing her first key informant interview, really trying to shape the context of how we view mental health, not only in a South Asian context, which is hard enough as it is, but sort of this intermediate migratory pathway, which is not captured in most data sets. And when I see not only the empowerment, the efficacy that they have, that they get, this is their conversation to have and to guide, it makes me feel like a proud uncle. Like, wow, you not only did a great job from a methodological standpoint, but the context you brought was not something that I would be able to provide in that. And I have that experience almost every day, if not every week, where some student who perhaps due to meeting me or read an article of mine, our interaction changed their world in a way that they didn't even know. And they get to dictate where that new journey is. And again, it's just today, I was just in a great mood because that person is going to now do this inclusive approach to South Asian health, which involves a population that perhaps the three of us never read about in the study. I mean, there's barely any South Asians in the studies that we read about anyway. But Indo-Fijian folks, Indo-Caribbean folks, they're never included in study samples. But they are communities that are under the South Asian umbrella and should be included as such.
Thank you so very much. That was really interesting because I did not know about Indo-Fijians and I did not know about that history with the partition. But I'd like to move on to asking you, what was the biggest lesson you learned in your career? And what is one thing you wished you knew a decade ago or so that you'd like the current and future public health professionals to know as they're building their careers?
I think when we are in undergrad, I think when we're in graduate school, I think when we're even in doctoral school and postdoctoral training, I think we think we're going to do something that there is a job title and a job description for. And the fact is, you asked me, what did I wish I would have known 10 years ago or whenever I was in my training stages? And the role that I hold now was not a job title that existed. And thankfully, there were people around me. Dr. Susan Ivey, who was in the inaugural board of the South Asian Public Health Association, one by Professor at Berkeley, Dr. Alka Kanea, which many of your audience members know about, the principal investigator of the Masala study, Dr. Eliza Tong, who does Asian American tobacco research. They basically said, we don't know what this thing is that you're going to do. We know what you want to do. So sometimes you have to make the job description. You have to get yourself into spaces where people are not having the conversation that you want them to have. Now, I'm a realist. You're not going to just go knock on the NIH door and say you're going to care about South Asian health. They're not going to let you on the grounds. So this is where mentors allow you to get your foot in the door and through their reputation, give you the credibility to speak. And I can't say that enough, that how many rooms I've been, virtual or physical, imposter syndrome is something we're always all going to have. We're never going to think we know as much as we need to know. But my credibility, my permission to be in that room was really based on somebody else who said, this guy needs to be here. He has a point of view and we need to listen. So they validate you. And so, when students come to me and say, well, what am I going to do with this? I said, I don't actually know what the title is, or I don't even know what the organization is. There is no Indo-Fijian health educator position that's out there right now, but I know at least 3 of my students are going to create it because it's important. And so the role that you take in the world may not be a role that is defined as of yet. And the exciting and daunting part of it is that you may be the one that creates it. And then it's incumbent that you do a good job with it, because if you don't, they're going to be like, why did we waste those resources or time giving you that sphere? And again, I'm going to say this, like SAPHA has really made this thing called being a South Asian public health professional a thing. There is an association, there's a website, there are resources, there's 2 publications, there's a whole host of track record that when I was Googling South Asian public health, yes, SAPHA did come up, but it didn't come up in the way that it comes up now. And you're going to have on your podcast series so many people that have paved the way for the next generation that we can be called and say, this is your charge, this is your value, and this is how you're going to do the thing you need to do. And you have a cadre of people who are going to support you, because we were very lonely at one time. And it was only 1 of us, 2 of us, 3 of us. Dr. Alka Kanea was probably the only person with national, if not international repute doing this work at one time.
Yeah, I think a lot of people who are doing South Asian health really had a similar start, right? Where they were the only ones looking at this. It's something that wasn't talked about. And so, that's why we consider people like that trailblazers, right? Because you're really paving the way for a lot of us now to we have these roles kind of already carved out because you were able to do that. And so a lot of the projects that you've started were also, areas that weren't touched before. So would you be able to share a little bit more about the projects that you're working on, any initiatives or research, how they align with your passion for public health, and then especially in addressing health disparities among South Asians?
Yeah, so I mean, my passion is the South Asian community. I mean, I'm a member of that community. I think of both of you as my sisters in the same community, right? Which is actually not true for many South Asian groups because they see a national divide and they're like, nope, you're somebody else, right? And so, when I see somebody, on my campus or whatever, and they have a name like ours, or they have um habits that are obviously very South Asian, I think of those as my people. And so, so my passion is South Asian health. If it's a disparity in the South Asian community, I care about it. It could be domestic violence, it could be COVID, it could be cancer. So I'm not a disease specialist, I'm not a risk specialist. A lot of my earlier work was done in tobacco control, and it wasn't cigarettes and Western forms of chew tobacco. It was looking at things like pan and gutka and pan masala and bidis, right? Which all of us know are South Asian, but the National Health Interview Survey would never pick up that as a tobacco use behavior. But I wasn't a tobacco specialist. And so fundamentally, the studies that I focus on really try and unravel this intersection, this complex dynamic intersection between culture, behavior, and environment. Some of the things that I'm working on, right now look at, why is colorectal cancer screening rates so low among South Asian communities? And it's not a function of knowledge, right? There's a general gut reaction that people don't do something, it's because they don't know. If you went and asked uncles and aunties, do you know that colonoscopies or cancer screening in general is good for you? Most of them would say yes. But then they'll tell you a whole host of reasons why they don't do it. And most of those are cultural. The key example is that a common theme I see is I would rather not know I have cancer and just sort of pass away than know I have it and worry about the impact not only on me, but the family who depends on me, right? Whether it be at work or as a parent or as a caregiver, right? So there's sort of a bliss and naivete about because cancer, no matter what it is sort of seen as this premature death sentence. And so I'd rather not know and let God's will have their way rather than go through this process. So, that's just an example of looking at sort of the belief systems that govern our existence and sort of how they translate into the ways that we actually engage in behavior, right? Um, if some clinic, just think of any clinic that has a large South Asian population, said, we're going to do a cancer screening workshop, guess what? Nobody would show up, right? Because we've already used a bad word. You put cancer in there, nobody's going to come for a variety of reasons. Similarly, when people pass away from cancer, they don't talk about it, right? I don't know why we think it's shameful that somebody passed away from cancer and we're not going to explain that. So there's these cultural worldviews that govern our existence. We know how that translates into diet. We know how that translates into domestic violence. So, and the one study that is just getting off the ground, and I'm very excited to have this conversation, is, really focused on why we don't have enough participation of members of the South Asian community in studies of mental health. Now, the three of us know mental health is not a thing, right? It's, there's pejorative language in all of the three of our languages that, we don't have words for DSM-4 or anxiety. It's usually something that's bad, right? And so how do we engage our communities to participate in studies that would elucidate these factors? And I think I can say it here because it's true, is that I'm really glad that through securing this funding, I'm able to bring SAPHA along as a partner, because one thing that Dr. Shah said, Umair Shah, was that the next 25 years, really we need to build the infrastructure and the foundation. And I'm under Samira's leadership, I've been really excited that we can actually put things together and actually pursue those resource bases. We always have to start small. And I think this will be a relationship. My relationship with SAPHA will be endless, but really putting my influence and resource on the table to advance the cause that SAPHA is so important about. So every study I think is important, but really drilling down to this idea of who are South Asians and where do those worldviews and beliefs come from that govern the environments and the behaviors that we know translate into usually poor health.
Yeah, it's we're very excited about the collaboration, and I'm looking forward to just increasing that capacity building for SAPHA to do more research and grant applications. It's really exciting.
Yes, we're really excited because we've been hearing about this collaboration at SAPHA too. And we're looking forward to what this is going to look like for us.
Yeah.
Now, you brought up the colorectal cancer study, and given the increasing rate of colorectal cancer among the South Asian population and the fact that Colorectal Cancer Awareness Month is coming up in March, the work that you're doing is even more important now than ever. So what are some lessons that you learned from it, and what does it mean for South Asians? And what strategies have you found to be effective in engaging and retaining South Asian participants in research studies like colorectal cancer? Like you said, cancer is a taboo word, but then it's also colorectal cancer. It's really hard to convince people to get colonoscopies. So what worked?
Well, not going
Or
to
what
purport
will work?
well, yeah, this is a dynamic field that we will always, community participation. So I'm going to answer the third question first, which is how do you get people to participate in anything research oriented? Communities have a viewpoint of what that word means, right? That, often when I used to go out and do things that I wouldn't do now, which is go to a mosque and say, come participate in my research study. And they're like, who are you? We don't know you. Your name suggests that you're not one of our people, right? That like all these things that I like completely bypassed, which are the most important things. So, and then what are you going to do with the research? Right? Are you going to take some blood? Are you going to take an organ? Most importantly, who's going to know what I tell you, right? And again, we've like those things are things that matter. Like I'm happy to share something with you in a focus group or an interview or a survey, but I'm more concerned about who will find this out that knows me, right? So these are, we know how our reputation in a community setting is so important. So one thing I've learned, which funding cycles are not very sympathetic to, is that to do community engaged work, you have to go be with community without an agenda. I spent the first year pre-COVID of my colorectal cancer study simply going to mosques and to temples and to cultural centers and just sitting there. So they got used to seeing me. And then some brave soul is like, so who are you exactly? So they opened the conversation, right? Oh, I'm here. I'm, first and foremost, I'm a professor. I do research, but I'm just here to, I'm not Muslim, but I'm just trying to understand, like, what is the worldview? So I'm just here as an authentic observer. I have no agenda, and so you start a conversation, right? Okay, well, why did you get interested in South Asian health? Well, I'm Bengali, and my parents are from West Bengal, and West Bengal borders Bangladesh. And it's very interesting because Bangladeshis are Muslim and West Bengalis are Hindu. But really, the thing that binds us has nothing to do with religion, it's language. Because, there was a war fought just on the autonomy of Bangladesh to maintain Bangla as their language, right? So, and West Bengalis get that. So you let them invite the conversation so that once you build your credibility that you are here just to be an authentic observer, then you can start to talk about things like, would you be interested in putting your perspectives out there, right? That takes years to do. You're not going to parachute in on a Juma prayer on a Friday and suddenly the whole Muslim community is going to trust you. So I think it's important that if we're going to do work, and just because the three of us consider ourselves South Asians, we have to remember that there's many South Asian groups based on our name or our religion or our generation don't consider us members of their community, right? So we still in our own communities have to earn the trust and the credibility. We can't assume that to be true. That being said, once you get to the point where, and if you do that right, then the world opens up to any kind of research, right? Because you've built the foundation. Then the question becomes, okay, what are you going, how are you going to understand? And I say worldview a lot, but it's so important, the worldview that people are going to want to or not want to engage in research with you. So, obviously I talked about sort of the who's going to find out thing, right? So, really talking about confidentiality, anonymity, informed consent above and beyond what NIH tells us, right? There's a cultural consent, right? That yes, even if I don't identify you by name, if I say certain characteristics, somebody's going to be like, oh, that's auntie that lives down the street, right? So we have to really have that cultural lens on how we look at things like protection of human subjects. And then listening to what do people fundamentally care about that may or may not have anything to do with health. Because the one thing that public health professionals and clinical professionals do a bad job of is thinking that people care about their health as much as you care about their health. People have to pay the bills. People have to raise the kids. People have to do all these other things that are antagonistic to caring about reducing stress, having a healthy diet, physical activity, getting screened, right? Because the world is a very stressful place prior to the pandemic, and the pandemic just sort of exacerbated that. One lesson I've learned, which, is contrary to what maybe the three of us learned in graduate school, was, we believe in these models of health behavior, right? Stages of change, diffusion of innovation, right? And there's some assumptions about that. And what I think people don't realize is oftentimes people make decisions for the interest of other people. And they're like, whoa, Dr. Mukherjea, that's so obvious. But what I mean is that when you think about our parents or our grandparents, right, they sacrificed a lot to make sure we had a better life than they did, to the detriment of their health. So they would gladly say, I will work 80 hours a week, knowing the toll it's going to have on me to give you a better life. Collectivism is something that we need to incorporate into our studies. So the individual, I don't know if it's true when you two were in grade school, but I remember people would come to me and say, don't smoke, your lung will look like this versus that, right? It's like, and I would always laugh, like, I don't even know what my lungs look like anyway. So all I see is a pink thing and a black thing, none of which resonates with my understanding because I've never seen my own lungs. I don't know what they look like. But the individual risk model doesn't work in South Asian communities because most people do things in spite of their individual health for the collective good. And if we use that frame to paint why we need research to create interventions that work at a collective level, your interventions tend to be more effective and more sustainable. The earliest studies of tobacco cessation among primarily Asian immigrant men largely failed because Asian immigrant men, they may or may not have known it causes disease, they didn't care. There's a masculinity involved in it, right? I'm the guy, I'm the father, I'm the husband, I get to do what I want, right? It's my autonomy that allows me to do this. Who are you to tell me what to do? But those same Asian immigrant men, once you told them that their smoking, by no fault of their kids' own or their grandkids' own, affected their health, in other words, your choice of behavior is going to harm the thing you care about more than you care about yourself, cold turkey, quit rates go up, right? So the frame matters. And so the underlying, I guess, foundations or conceptual models of my research really stem from, again, the core understanding of our worldviews and our social organization. And then you can find out, oh, we don't say cancer. Then you can find out, okay, domestic violence, we're really talking about the underlying issue of patriarchy, right? And then it gets complicated. But your interventions and your discussions that lead to those interventions tend to be more fruitful in terms of things that are actually going to work rather than the thing that follows the stages change model.
Yeah. I think that's a really important point that you brought up about really shifting the frame of how we approach research with this community. I mean, I think getting South Asians involved in research has been a major achievement over the past couple of years, because we're finally looking at South Asian health. And I think that's getting a lot of people excited to really get involved in this field. But also, over the past few years, it's been a bit of a challenge just to do public health work. With the pandemic and just a lot of the things that are happening around the world, a lot of challenges are being brought up, and the public health workforce and community is under a lot of scrutiny.
Sure.
And so what advice would you have to motivate the next generation of public health professionals to keep doing what they're doing and not lose hope in the impact of public health work?
I mean, that's hard because with any profession, you sort of shift where the political and economic winds takes you. And that's why I'm going to say what I said before, your values shouldn't shift, right? If fundamentally the three of us in this room and everyone listening to us fundamentally cares about the well-being of their community in the same way that they care about their parents or their grandparents, then we're going to have to make it work no matter what, right? SAPHA has existed for 25 years despite the most compromising of circumstances, right? And not only survived, but thrived, right? And I'm not saying that as lip service. I mean, where you've taken this to, whether it be, working with the National Coalition of South Asian Organizations or getting invited to places where NIH or CDC want to hear you, to all these places where the founders never could have thought that you would be there and shaping, like supporting policies that focus on South Asian heart health, which I know is stalled in Congress. But I couldn't have ever thought there would be a bill on South Asian heart health led by a congressman, right? So these are all things that, we're going to do it because we have to. And I go back to my key man, if nobody else is doing it, why can't you? And then it's not just why can't you, why do you need to? Because I know that if I wasn't there for many of my students, they would have gone and found something that was completely unfulfilling or to the what their parents wanted them to do. And not to say their parents are bad people, but parents also have a context, right, of how they shape those decisions. So public health is here to stay. It has been here to stay forever. It will not go anywhere. The CDC will not go anywhere. The NIH will not go anywhere. Our state and local health departments will still be public health departments. And when we have that government-based infrastructure, there will always be resources and opportunities. Now, do you want to be a South Asian health educator? Probably not. So we have to work within the existing infrastructure to say, public health department X, you say you care about health equity. Here is a way that you are not even elucidating those inequities by aggregating your data. So explain to me why you're doing that, especially when your population is 40% Asian. Does it make sense to do that? So, we sort of have to respectfully bully our way into places where, people haven't even heard from us or don't want to hear from us. But I don't think in my career I've ever heard of anyone saying, I want to do all this work, etc., but I wasn't able to do it because fundamentally there was an opportunity for me to do so. Now they have to shape that opportunity. You can't be a passive participant in this. You have to, and you have to leverage your mentors and people who have done this before to really get you at the table. And I think any successes I've had as a mentor is to be like, okay, not only will I guide and advise you, but use my name. And let me introduce you to a power broker to give you the credibility to be in that room. But I think public health, if the silver lining of the pandemic is that people now know what it is, it's not going anywhere. And if, again, you have an underlying value system that focuses on prevention at the population level and hopefully understanding that South Asians are part of the mosaic of equity and diversity in this country, I don't think you're going to have an issue. You're going to have to fight, but I don't think you're going to have an issue.
That is awesome advice. So Dr. Mukherjea, we've talked about your journey in public health and about the amazing work that you've been doing recently and in the past. And we've heard about your experiences as a researcher and as a mentor. So now we'd like to spend some time talking about your experience with SAPHA, especially given how closely involved you've been over the years. So you mentioned this briefly earlier, but can you tell us a little bit more about how you became involved with SAPHA and how your experience with SAPHA influenced your career trajectory or your personal growth in the field of public health? And what advice you might have for future professionals getting involved with volunteer opportunities like this?
So when I got that sage advice, if nobody else is doing it, why can't you? The first thing you do is, okay, has anyone else tried to do this, right? And a lot of, there weren't many people at all, but most of the people, all like two of them, were doing clinical stuff. And then I randomly fell upon this thing called the brown paper. And, I was like, what is this? I love the title. I mean, whoever thought of that was just like so awesome. And I remember I went on the website and I'm like, oh, and you had to buy it at that time. I think it was like $25. I'm like, I can't afford a $25 for, this book, and you have to pay for shipping. So I reached out to this guy named Abhijit Ghosh and I said, look, and they were looking for people to really try and get the word out in local communities, right? And I reached out to Abhijit and I said, hey, I'm this random guy who wants to do South Asian health. Is there any way for me to get involved? And he goes, we would love it if you could, in your academic setting, because I think the intention was to create a body of scientific literature that could be scaled up through the dissemination in academic circles, because that's really where literature is sent out. So, having been at that time a two-time graduate from Berkeley, I think he was like, yeah, can you get the word out? And so he sent me a free copy. So that I bypassed the $25. And I read it. I'm like, this is amazing. And I remember having a thought, like, I want to write a chapter on this at some point. And lo and behold, for the next one, I got to write a whole one. And that was really exciting. So I think Abhijit, I can't speak for him, and Ushma, but Abhijit was my primary communication. I think he saw like I wanted to do something really badly. And if it could leverage SAPHA's interest, which you have this cheerleader giving away free books, perhaps there are other things we could do. And so I wanted to be on the board. I'm like, I want to be part of this group, not because I wanted a leadership opportunity. I wanted to be in a space where I didn't have to explain why South Asian public health was important. There's a picture of me that I have somewhere, which is my first APHA meeting that had the SAPHA panel in 2003. And I just remember what a gratifying feeling it was to be in a room of people that looked like me and that cared about the same thing that we cared about, that we could talk about social determinants in a South Asian context. So long story short, that's what got my foot in the door. I ran for the board and subsequently got elected co-chair with my dear friend Shilpa Patel, who's over in Atlanta. And really the goal there was, and voluntary boards are always like this, they want to take on the world. But they have to do it on their spare time. And our goal was really to create a national platform in which SAPHA was seen as the first stop for anyone that wanted to do South Asian public health. That was the goal, so that it wasn't by accident, that people knew that if I want to do this, the first place we should stop at is the South Asian Public Health Association. And then the question was, if they stop there, what are we giving them of value? And in those initial years, and when I say initial years, the first 4 years, it was the network. That's all that it was. Capacity building, that somebody in grad school could say, you know what? Not only I want to do this, I can do this, and I have 2 people I can call to help me do this. That's what Dr. Susan Ivey was for me, which was the person who I could call to say, oh my God, I don't know what I'm into. And she was there like, look, we knew this was going to happen. This is how you address it. So SAPHA, really my first term was really about capacity development, including, as both of you know, capacity development for the board. Because when you sign up to be on a board of directors, nobody tells you what you're going to be doing or not doing. And every chair, every committee coordinator has their own way of what they think is going to happen. What I do know is that you identify small things that you can win, and you win. And that sets the stage for the next thing. So in my first board, people are like, we should go apply for NIH grants. I'm like, oh my God, like really? But now 25 years later, we can say that with a level of credibility that we are having conversations. I'm not even saying federal funders are reaching out to SAPHA to say, how can we fund this, right? So there was the dream to say this was the one-stop shop for expertise. And that was the goal, was to really disseminate the role of the brown paper. Dr. Umer Shah talked about the fact sheets. That started on my board because one thing we said was, it's one thing to create a piece of academic literature or scientific literature. How does a person at a nonprofit pick this up and do something with it, right? You can't talk about prevalence, incidence, risk ratios, all that stuff. You have to have it in a digestible way. So I had that stint of the communications. That was part of what we're trying to do, is make this distillable at a community level. So the person running the CBO could pick it up and say, okay, community member, here you go, but how does it also inform their program planning? And being on the SAPHA board was something that it was hard, it was difficult, challenging, but it was some of the most enjoyable time of early in my career.
Yeah, I mean, I think what you've said resonates a lot with the current board and people who are listening who are on the previous SAPHA boards. It's just, you put in so much time and energy, it becomes like this pet project for you that you really want to see grow. And I think what you said about how it's been one of the most enjoyable moments. It's something that I think a lot of us agree with, myself especially. But would you be able to talk maybe about one specific or a couple of your most enjoyable moments during your time with SAPHA?
Oh, wow. I'm trying to think of, I always want to think of a profound one.
Well, it can just be something silly also.
No, again, I thoroughly enjoyed being part of at least 3 boards, right? Because we had staggered terms. And so it's like, even though I was chair for X amount of time, it was really chair for 2 different boards. And I really authentically, the friendships and the relationships that we built, because we were so alone at that time, really supersede. Even though I haven't spoken to Ushma in 10 years, I could pick up the phone and we could start off wherever we left off, right? So there's this kinship of shared experience that really binds us together. And, Samira, I have that with you, right? We've been doing these things for so long that it's just organic. I think, some of the most important things were that so I remember one initial experience where CDC launched what's called the Adult Tobacco Survey. And so it's like a validated survey trying to characterize tobacco risk. And I think the fact that CDC reached out to me, not as a researcher, not as an academic, but as the chair of SAPHA at the time to say, we've read some of your work, we've seen your policy recommendations, and what you're saying, if we're truly sincere about understanding and reducing tobacco-related disparities, the fact that you're talking about products that we don't even measure is important to us. And I've had a multitude of those experiences where either me or somebody on my board was invited to a place where they wouldn't have otherwise been invited to had it not been for the credibility of the South Asian Public Health Association. And none of them are as dramatic as going to CDC and going to, if you've never been to CDC, it's quite the experience, right? Because you have to get like a background check and all these things. And it's like, here I am, a 25-year-old, and they're asking me for, let me have a go do your live scan fingerprints because we need to run them. And I'm like, what's going to happen, in Atlanta? So I think those are really the enjoyable moments. The fact that Vivek Murthy in his first iteration as Surgeon General actually knew what SAPHA was, right? It's like the Surgeon General of the United States knows this acronym, right? Those are really the things that made me proud. It did make me proud as an individual, but really as a steward of the organization to be in those spaces where the name meant something. And it doesn't have to be the Surgeon General or CDC. It could be your local health department. It could be Narika or Maitri saying, we read your fact sheet on domestic violence. These are established organizations that have done this work, but they know who you are. Those, I think, in some have been some of really the most enjoyable times to see the fruits of our labor, because you two know this. The time you put behind the scenes and the actual product, when people is like, there's a disconnect because you may work really, really hard on capacity building, and all you have to show for it is like, here's my compendium of South Asian health sessions, the APHA. And they're like, it took you a year to do that? And you're like, no, it didn't take me a year to do that. But the work that goes into thinking of that through does take a lot of time and effort and emotion.
Yeah. Yeah, and I think a lot of the projects that the previous boards had started, it's like the compendium right now. It's because of all the work that you all put in back then. Now it's like second nature to us. Like, okay, APHA is coming up. Let's put together a compendium. Like, people know what that is. They know what to do. And I think a lot of people don't realize how much work went into it at the beginning. And I think that you can say the same for a lot of the things that SAPHA has achieved, right? Over the past 25 years, we've obtained 501c3 status, just became a nonprofit. We've published influential research. There's been awards that have been received. We've done a lot of that critical partnership building. And then a lot of the legislative advocacy, right? You had mentioned the South Asian Heart Health Awareness Act. I think that act itself has been advocated for by at least 3 to 4 SAPHA boards since before I started. And like we've, established a presence in DC now with, PCORI or the CDC reaching out to us, engagements with the Secretary of Health, invitations to the White House, and working with a lot of these key organizations. And so the past 25 years has really seen SAPHA go from just an idea to a full-fledged organization. And so given all of this, where do you think SAPHA can be most impactful in the next 25 years?
So because it has established itself as a credible organizational expert in the field, now I think the next step is, what do you do with that credibility, right? So they come to you and you're like, that's great. I'm glad you came to us and this is a thing. But then what do they do with that, right? So I think you've heard this being echoed by my colleagues that have spoken before me, is now we got to build a resource base. And again, I'm not just saying that. I think, Samira, you and I talk on a weekly basis about what our next step is. And I think, sooner than later, you're going to probably have a wonderful announcement to make to the SAPHA world about, building that resource base. There is going, hopefully there is now a staff, right? Hopefully there's a paid executive director, right? So I think before, I would like to see it move from voluntary to more formalized structure, which means that you need to have a consistent, sustained base of revenue. And what that means is that members who are interested now don't speak with their hearts, but also through their wallets, right? And I know that sounds very capitalistic, but ultimately any membership organization, and if you look at APHA, right, as as the most credible public health association, the three of us know how much we pay to go, and we gladly pay it, right? I mean, I think that most people would agree it's ridiculous how much we pay, but we're paying for the experience and the network, and we don't think twice about it, right? For the most part. And so am I thinking that we're going to get to that level? No, but it's like, what is the buy-in that a paid membership base would actually get benefit from, right? And if SAPHA is good at going to be successful at securing these resources, whether it be, working with me on the mental health, grant to get more people engaged, or whether it be talk about dissemination grants, that means that by virtue of those resources, there's going to be opportunities for people to get involved in a more meaningful way than a voluntary board, right? Because grants come with paid time. Paid time can go to interns, right? So I know one area, I think that was under your board or maybe the previous one, where SAPHA did have a paid intern for a little bit of time, right? But you need sustained resources to do that. So once SAPHA becomes good at doing this, which it will be sooner than later, then we understand that, okay, we need to create line items that one intern turns into three. Maybe we need a doctoral student. Maybe we need a postdoc, right? Not because those are the most important people, but the funding agencies understand what those people are, right? And they're more willing to fund those. And then, you get there. So ultimately in 25 years, I see SAPHA being more than a website, which is great. I see SAPHA with a physical home. I see SAPHA with a paid staff. I see SAPHA with a registered lobbyist in Washington, D.C. I see people who proudly wear the SAPHA name on their affiliation first, as I do with mine, right? When I introduce myself. That's what I see. And I see, just like many other organizations where you have people early in the training pipeline, endeavor to be a SAPHA intern, a SAPHA fellow, a SAPHA resident, right? And ultimately, when the formality comes in, all the things that the three of us talk about on a regular basis of, God, I wish I could do that. Now we're going to be doing it. What will be very important for the future boards of SAPHA to realize, it's not only enough to secure the resources, we have to do things with the resources, right? We can't simply be appreciative that we landed this $10,000 grant, this $100,000 grant, this $1 million grant. If we don't produce, you can easily reverse 2 decades of work with a simple fail. So it's going to be incumbent on any future leadership to recognize that with those resources come responsibility. Luckily, the history of the SAPHA board knows this because it's part of their job, right? I know when I secure a grant, if I don't deliver, I'm not going to get my next grant, right? So you have this historical world to really lean on to walk you through that. And no, I'm just so impressed with where you are. SAPHA's presence at APHA is now a common thing, right? It's just taken for granted. You're right. People wait for the compendium to come out. It wasn't like you're doing people a favor. The people like me will email and say, when is this coming out? Because I can't do my schedule without it, right?
Right.
So it has become intrinsic in people's realities. And let's make that reality a little bit more formal, structured, and have actual resources and formal titles behind it. And concurrently, if we're doing all that, that means we're doing the work that the inaugural board only dreamed about happening when they started this 25 years ago.
Thank you very much. That's a lot for us to look forward to, but we're going to be ambitious and we're going to work hard towards that. So this has been an enlightening and very engaging conversation for the both of us, and I'm sure our listeners have had a lot to take away from this. Do you have any closing pearls of wisdom for those aspiring to do work in South Asian public health?
So I hope that the people who watch this or the people who watch the previous ones know that all of us that are in front of your virtual Zoom screen would welcome you contacting us. Reach out, right? Yes, we're busy, but I think, again, because it is, I don't even want to say labor of love, but it is endemic to who we are as people. Please watch these podcasts, reach out to those people, because they are here not only to share their histories and their successes, but also to make sure that you have even more success, number one. So that's the one thing I would say is that for people watching this to do. And secondly, doing South Asian public health is a thing. It's a career track. It's not something you do on the side. It's not this pilot niche project you do on top of your real job. So in addition to, reaching out to us and really helping us navigate whatever path you define for yourself, consider public service on a place like the SAPHA board, right? Because this truly is public service. And I guarantee you, and I don't say that very often, the things you'll take away from it are going to be more important than the things you give to it. To be able to have a conversation with some of the people that you've talked with, you didn't think you're going to have those conversations or be in those spaces, but by virtue of doing it, you enriched SAPHA, but you also enriched yourself. And so, you know, when I talk to people who are later on in their careers, I say, do me one favor before we have a conversation. Go read your statement of purpose for graduate school, because that was an unencumbered statement of your values. And ask yourself, am I getting closer to that or am I getting farther away? And if we use that statement as theoretically a statement that articulated your values, then let's follow that. And know that you just have, again, now I can count on 10 hands how many people do South Asian public health, that there are professors whose research agenda is South Asian public health, right? Many of them, if not most of them, were people who sat on this board. And that means you could be the one having this conversation in the next 25 years podcast about your story. And that's what, that's what old uncles like me wait for, to see the next generation really take this on, because the world has gotten more complex and we need bright young minds to really shape what the agenda is.
Yeah, thank you, Arnab. I mean, this has been such a wonderful hour conversation. Thanks for sharing your insights and your experiences with us today. It's really been an honor to have you here. I'm very excited that I was able to host this, just because I feel like I've been talking to you every week, basically, but
I know, right?
to have like a formal space to do that. And so we're really, honored to have you here as a guest on the SAPHA Spotlight series. So thank you again.
Well, and I'm humbled to be here. I can't tell you, this was like the perfect way to end a week. And I couldn't think of anything better than having a wonderful conversation with two of my sisters in the cause. So let's continue our work together.
Thank you very much, Dr. Mukherjea. To our listeners, thank you for joining us on this illuminating journey. Please stay tuned for more conversations with past SAPHA board members and leaders in the field as we continue to explore the diverse narratives shaping the landscape of South Asian public health. Don't forget to follow us on YouTube and Spotify for updates, and consider supporting SAPHA's mission by visiting www.sapha.org. Until next time, this is Loin and Samira signing off.